So I'm just going to say a few words before we start the final session. I just want to make a couple of brief announcements. The first is to say, and I didn't say this morning in all of the thanks, and I do want to say it, the very first global burden of disease was supported by the World Bank. But this particular version of the global burden of disease was supported by the Bill and Melinda Gates Foundation. The Times put it as the Bill and Melissa Gates Foundation this morning, unfortunately, but I hope somebody writes to them to correct that. But the Gates Foundation has invested, as you know, they've indeed funded originally the Institute of Health Metrics and Evaluation and have been the investor in the Global Burden of Disease study. And the Gates Foundation invests in many things and does a lot of public good, but I would say, as an observer, an outside observer, that the global burden of disease is the biggest and best return on investment of any project that they have put their money into. And I think we do need to recognize and thank them for that long-term support and indeed continuing support. A few little figures. We had about 450 people attending today. There was an overflow room somewhere else in the Royal Society where people were. There were 13,000 views of the webcast, which is fantastic. Which is the largest number of views of the webcast ever in the history of the Royal Society. Going back to 16 or whatever, because, of course, they had the web in 16 whatever it was when they were founded. Now, I hope you've all been tweeting. I've been madly tweeting everything, every slightly embarrassing comment people have made. I've certainly tweeted. Now, one person tweeted, I don't know if it's somebody who's here, all I know is what she calls herself on her Twitter feed. She just calls herself Olga. Anyway, Olga, whoever Olga is, said, "Why is WHO not in the room? Have WHO been invited to participate and respond?" So I need to set the record straight here because we do have somebody from WHO here, Colin Mathers. Colin, are you here? Yes, there you are. Great. So at least Colin is here from WHO. As you will have noticed, the Director General has written a comment in the issue as well, in which she warmly welcomes the GBD. And we did invite Dr. Chatton to come to the meeting. She has a very busy schedule, was not able to come. But I certainly know that if she had been able to come, I'm sure she would have come. So we definitely are on good terms with WHO. Just let me make that absolutely clear, just in case there's any concerns about that. Well, what does all this mean? That's what we're going to ask in this final session. So we have a stellar panel, some of whom you've seen before, but we have a new member of the panel, and I'm going to briefly introduce each of them. The first member of the panel, and I love her business card, because her business card puts everything in the right order. Dr. Christine Kaseba-Sata, the first thing she says is, obstetrician and gynecologist. And then it says, First Lady of the Republic of Zambia. I like that. A woman who's got her priorities right. And then, of course, we have Mickey Chopra, head of health at UNICEF. We have Tora Goodell, advisor to Prime Minister of Norway, Jane Halton, who basically runs Australia. We have Christian Baiza, who used to run the World Bank and is now at McKinsey. And we have this chap at the end, I can't remember his name. Right, now, the first question I'm going to just ask two questions, and we're going to do one each and go up and down the panel. And then really it's up to you. And really this is about what does it all mean? So the first question I'm going to ask our panel is, what is your one overriding conclusion or impression from today's meeting? And I'm going to ask our resident obstetrician and gynecologist, First Lady from Zambia, to give her initial remarks.
think it's important for me to start by thanking the organizers for inviting a First Lady. I think to me it shows that you are slowly coming to recognize the potential that First Ladies have. I always say they have the ear of the very high places and they can actually influence a lot of policy changes, especially more so in Africa. It's been very interesting listening to the presentations throughout the morning and the afternoon, and I'm put in a fix because it's asked for one thing that stands out. But one of the issues, maybe from the perspective of my being an obstetrician, women have always been central to my thinking. And looking at the data and the burden that has been presented, while it's very good to start influencing policy dialogue, to start up policy dialogue, for me, my concern really is where are we putting women's health? I mean, are we masking women's health, adolescent health in the whole aura of the global burden of disease? And what does this mean for funding opportunities towards women's health? And especially in sub-Saharan Africa, where you have to really take into consideration the social gender disparities that existing. What is this going to be able to do to the women in Africa, to the adolescents? One of the, I think, presenters talked about the need to focus on the adolescent and the young adults. For a long time, they've been ignored. But we know for certain that a lot of things that tend to happen in adulthood are as a result of the way we manage the adolescent, the way we manage the childhood. We're talking about obesity. Obesity starts from very young, and if we do not correct it, it will transcend into adulthood. So really there's need to disaggregate the data that we have, especially in sub-Saharan Africa, which really depends on data to inform policy. We need to start disaggregating the data and be able to tease out the important issues that affect women. Otherwise, there's also a danger that the global world will also focus on ischemic heart diseases and leave out maternal mortality. I know you said one thing, but the other good thing, I was just saying yesterday, for a long time, we've been talking about the disability associated with maternal mortality, and we never seem to make inroads in people understanding the disability. But because now we're talking about general disability affecting the men, there's more focus and more attention, but I hope that at least you will be able to note that apart from women dying, a lot more survive with a lot of disabilities, and in sub-Saharan Africa, because of the cultural constraints, many would not even talk about them. Many would not even seek care because of the embarrassment and the social isolation that they have to go through.
Thank you very much indeed. Fantastic. Mickey?
Yeah, the one overriding impression for me is one of the potential of this huge amount of work to forward our joint agendas. As you know, we're leading a big movement called A Promise Renewed, which is really saying that we can end preventable child deaths by 2035, and that one of the first sort of steps that we're encouraging and working with partners around is to re-engage stakeholders, first ladies, policymakers at the national level to re-look at their burden of disease, re-look at the causes of death, and re-look at where and why children are dying. So the richness of this analysis will be a real driver and push behind that. But obviously, for that to happen, as we talked about this morning, the need for us to have that transparency and sharing of data sources, of looking at the assumptions, picking the best way forward and picking the best quality data is going to be critical. So I'm very excited, potentially, if there is such a thing, to really use ride this wave of investment that's been made in a way of really engaging at the national level, and absolutely, as the First Lady says, to try and to hone in on the very different messages that will come when you look at specific population groups in particular. And it is a worry of mine that the big message is, someone told me the headline yesterday was obesity more important than hunger. That we don't lose some of the unfinished agenda that is still affecting the most poorest and vulnerable, and that's not the fault of the study. It's the way in which we're packaging and using this data, and getting to the signal and trying to get out the noise is going to be critical for us.
Thank you, Mickey. That sense of potential excitement, that's a marvellous feeling. We all want to feel that. Tori, are you potentially excited, Tori?
So I have to, you're usually very factual, Richard, but I have to correct you on one thing, and that was, what was the best investment by the Gates Foundation.
Oh, yes, go on, tell me.
So,
Gabby.
In 1999, I was the recipient of a check of $750 million, and Bill Gates said later that his hand was shaking when he was signing it. And it was based on a 5-page application because he should read it on the golf course. And so that is the standard for research councils. And then 4 years later, he said, together with Melinda, it was the best investment they've ever made. So that was the correction. Then I had 3 quick points. I think the relative benchmarking, that you really can do that because that will create competition into the system between countries. So I think that makes me really optimistic this time. And I hope I will not be as disillusioned as I was last time in a way. The second point, I think, I want to really go with Richard here in relation to the risk factors and the two. And I think you have to understand the sea of misinformation that we have in relation to foods and all kinds of things. So unless you're able to take something simple and let it stand out, you are not going to rise above the noise. And I think if we cannot get tobacco right, alcohol and foods are going to be much harder, much stronger forces against us. So I think that is a real pathfinder for this area in many ways. And then I'd just like to support you, since we are fighting upstream for women against men in terms of their health and social opportunities. And in Norway, the analyses have been made. We have tripled our GNP over the last 30 years. The most important factor has been to be able to make women participate in the formal sector, more important than our oil revenues. Thank you.
Very good, very good. Thank you, Tori, and thank you for correcting me. Jane.
Thank you, and I will also issue a tiny correction if that's all right. Never to be outdone. I think you have to include, and because we of course have a female Prime Minister in Australia, it's not just first ladies, it's first blokes as well. To make sure that we have the gender balance just right. The overwhelming impression I have of today is actually not only a sense of anticipation and excitement, but also a sense of the work to be done. Because I do think we're actually on the threshold here of something which, from a health perspective, is really groundbreaking. It's game changing, and I was sitting jotting myself some notes about what work needs to be done, and that is the conclusion. That is my overriding takeout from today. And I've kind of classified them in my own head, and they may or may not be useful categories for you. The first of which is actually the work itself and the institutional arrangements that underpin the work. It's the debate about the disability work. It's the debate about the risk factors. It's doing something about civil registration. It's doing all the things which actually underpin the science and improve the foundation on which all of this rests. And that, it strikes me, is really important. The second thing is actually getting it known and getting it utilised. And Tora's point, and for those who don't know, I do spend most of my days running the Australian health system, not playing around in universities, but I do have a finger in nearly everything in Australia. That's very true from a health perspective. But Tora's point is absolutely right. Essentially, having the work known and understood in an academic context is not enough. It's getting the word out so it is actually used in a meaningful way to actually deliver outcomes to the people that we are trying to provide service to. And from that perspective, then it strikes me that the third way I've been thinking about this is the content. What does it tell me in my day job, what I'll do on Monday morning when I get back to Canberra? What does it tell me about service design? What does it tell me about priorities? What does it tell me about purchasing? What does it tell me about policy formulation? What does it tell me about the global versus the local was the note I jotted myself. Now, in my context, that means what does it tell me about the challenges to deliver services to Aboriginal and Torres Strait Islander people as against to white middle-class people who live in Balmain and Sydney? And you can parallel that up or down, however you like. So those are that's really my takeout. There's an awful lot to do now. But unlike last time, and I understand that the issues about last time, and we do use DALIs actually to make purchasing decisions, Tori, you'd be pleased to know, in pharmaceuticals in particular, but in other areas as well. Unlike last time, and we had a conversation at the IHME board about this, in a way there's a parallel here to what economists take for granted. And they all publish, governments publish current accounts, they publish a whole series of economic data which actually govern the operation of policy. Reserve banks pay attention to it, etc. In a way, this is the health version of that. And as it becomes a regular publication, it will become the kind of thing that you will refer to. What is my health account like? How am I going? What should I be looking at? What should I be investing in? Should I actually run the flag up the pole more on alcohol, tobacco, whatever it might be? And again, that's one of my takeouts.
Very good, thank you, Jane. Christian.
Thank you very much. I am definitely excited. And so three very brief reasons. One, I see a new model of collaboration that is really shaking the governance of global health discussion. I used to be the head of health in one of the multilaterals, and there is a sort of a feeling that we own, we have the authority to own it forever. And I think this is shaking it, and it's really welcome. And it also introduced a doses of independence to the assessment of what is happening in health and the impact of health. The second take home for me is the impressive reduction in mortality, but the increase, therefore, of tremendous increase in the relative importance of disabilities. For me, doing a parallel with macroeconomics, the 70s, the 80s, the early 90s were all about, controlling inflation, very macro controls. And then today is all about micro. It's how do you do inclusive growth, inclusive effective growth and competitive growth. So I believe that this moment and this study is marking a point which likely we're going to move from the sort of the macroeconomics of epidemiology, talking about mortality, which has been driving our conversation, to the microeconomics of public health, which is how do we tackle now not only keeping people alive, but keeping people healthy. And my hope is that we will be talking about health, not only about healthcare. And the fact that it's difficult, it doesn't mean that we should not talk about it. It is not out of scope. It's interesting for many, many years to me to hear that ministers of health define themselves as ministers of medical care, and that health is out of scope. My third take-away message here is that I think it has huge implications for development. And I will use the little piece of left heart I have, saying that for me, the global burden of disease, it has a huge implications on fairness and justice in the allocation of development health assistance. I believe that this piece of work allows once and for all to move away from the notion that if you have a fantastic advocacy machine, you will get the money. If you don't, you will not get it. It gives voice to those who do not have voice. It gives voice to the evidence base of who are actually in need of the resources we need to allocate. So for that, I would like to really thank IHME and Lancet, and personally you, Richard and Chris, because it's beyond global burden of disease. You've been doing this for a long time, bringing voice to those who do not have voice in development assistance for health. Thank you.
Thank you, Christian. That's very, very generous of you. Professor Murray, what's your one overriding conclusion of today? And it can't be, thank God it's over.
It can.
So my main take is, and I'm going to get a T-shirt that says this, which is, beware of Richard Pito at the Royal Society. My slightly secondary take is this was actually probably, potentially was worth doing. To quote Mickey, but no, more. I actually, this has been very gratifying today to get the diverse ways in which this giant effort by so many people is actually seemingly energizing, and I think can prove useful, and it's huge motivation for us all to try to keep this going in the future. So that's my main take.
Okay, I've got a second question, but I'm going to do that after we've had some questions and discussion in the audience. What does it all mean? So, please, I want to see some hands going up, and we have some microphones at the very back there. Hands shot up. As usual, just say who you are.
Hi, my name is Zubair Kusha, and I'm from the UCL. I'm a student there. One of the things I noticed was that I find it's very interesting and doing global health, and I think it's very helpful that we have somewhere where there's a huge amount of data that we can sort of refer to and learn something from. But also there was mention that we are doing this because of actually implementing policies and changing policies and making real changes. Somebody quoted Marx that the point is to change the world. But one of the things I think was maybe not mentioned a lot was the trade aspects of health. For example, one of the institutions that I think are very important that was not mentioned a lot was something like WTO, and has an institution for a forum for trade agreements between countries. And one of the things that WTO has is called TRIPS, which is trade-related intellectual property rights. And my basically question is that even if these policymakers were understood what was needed to be done, and they want to do something about it, and as we know that one of the neediest countries in this world in terms of health are the poor, that is very difficult for them to afford these things. And what I believe is that TRIP does is it makes it very difficult for these countries to implement interventions because of these patent rights that stops them.
That's great. That's a very good point. We're going to put how we solve TRIPS problems to the panel in a moment. Please, yes, over here. Oh, Sandy. Yes, for you.
Sandy Cairncross, London School of Hygiene and Tropical Medicine. There have been several comments while I've been here about the great contribution of this work towards transparency and health information at global level, and it is a great contribution. But we mustn't forget there are still a few black boxes in the process, and I look forward, to give one example, in the risk factors session, in the risk factors paper, there is mention of about a dozen meta-analyses, none of which, as far as I know, has yet been published. So I look forward to seeing those missing links in the logic all being published as soon as possible in a peer-reviewed journal such as the one you preside over.
Very good. Thank you very much indeed. I'm looking at, yes, please, I'm going for gender equity here as well, seriously. So there's towards the back there.
Good afternoon. Thanks, Richard, for replying to my tweet. My name is Olga Kolichenko.
Olga! Yeah. Hooray! Well done!
Thank you very much for the discussion today. It has been really enriching and interesting. I have two short questions. One is the follow-up to my tweet, and the question is, so we discussed quite extensively today the importance of improving the national health systems. So who would take the ownership of this? And what's the role of WHO in this, and how prepared are the governments to improve the national health systems? And second question is, I represent International HIV/AIDS Alliance, but also Action for Global Health Network. So what's the plans for the research consortium to get engaged with the civil society and with the advocacy networks working on global health, so that we spread the word and engage the public in this information and data? Thank you.
Thank you very much indeed. Peter.
Peter Bias from the Umeå Center for Global Health in Sweden. Chris, I completely agree with you. It was worth doing, and congratulations on doing it. This is a great abstract of this piece of work, but I think the work is so huge that it's not much more than an abstract. The visualization tools and so on is the next, and the appendices are the next sort of great layer in the whole thing. But I think it is very important, as as we heard both from Irene Yapong from Ghana, and as we heard from Dave Leon earlier on as well in the panel discussions, we need a very clear agenda as to how we're going to achieve global ownership of this whole process, and global ownership, I would say, in the sense of enabling access to yet drill down further into the data by the global community in general, or at least those of us who are interested in those kind of nerdy things. Thank you.
Thank you very much indeed, Peter. There was a question just down here, a woman with, yes, that's it, that's it.
Hi, Nicole Johns from IHME. One of the really interesting things from the earlier iterations of GBD has been the sort of ethical debates around things like age weighting, discounting, and the disability weights. And I'm curious if you guys have any thoughts on what will be the next big philosophical debates around the GBD.
Do you think it was worth it?
Absolutely.
Okay, right. So I'm just on this point about 12 meta-analyses and where and when are they going to be published. Chris, the black boxes.
So I think across the 486 collaborators, there's a very ambitious set of publication plans that each of the groups have. I think when we added up the currently planned set of publications, there's more than 200 in preparation. I think perhaps the most ambitious is Harvey Whiteford and his colleagues on mental health. But there's plans across the risk factor groups and the disease groups to really try to lay out in huge detail. And they're not all going to go to the Lancet. So rest assured, Richard.
Okay, very good. If I could turn to the First Lady, actually. This question about, so we have all this stuff, and we want to get it to countries. How are we going to do that? I mean, you know, we've as Peter says, the booklet's an abstract. So what's going to happen? What do we need to do? What do we need to do to make that work? Get that ownership?
Probably I can turn the question to you. How did you do it for London, for UK? You know, I guess you took it to the policymakers, yes. But you really have to unbundle the findings in a language which is going to be easily understood by the policymakers. If we look at sub-Saharan Africa, I mean, you've got the double burden of communicable diseases and increasing the rising instances of non-communicable diseases. The dilemma will be, how do you go to them and really tell them you need to deal with the non-communicable diseases without compromising what you've already been doing on the communicable diseases, right. You know, and still stay on course to be able to provide the goods and services that are expected in terms of education, housing, shelter, sanitation. So we really have to make sure that at least the countries own the data. about themselves and be able to participate in analyzing the data and be able to come to agreement on whether the priorities that have been identified within the study are the same priorities that they're already attending to, they're already seeing. It might be that we also need, I think this also came out really very strongly, that for us to be able, for the countries to own the data, you've got to strengthen the data capture, the health informatics, because maybe the reason why certain priorities are not coming out is because of the lack of data and the completeness of the data in developing countries. So, well, for Zambia, you can take it upon you that you can be assured that I think the president is already aware that I'm here. So I'll start softening the ground. And we've got people within this room from the ministry, cabinet, and public service commission who actually take on the mantle of ensuring that the health systems are strengthened in terms of infrastructure and human resource, which is a major constraint in sub-Saharan Africa.
That's right. Now, Jane and Tore, you are senior government advisors in your respective countries. So from a slightly different perspective, how are you going to take up this information and feed it back to your governments?
Well, we have invited Chris. To a meeting with Britain take place on the 23rd of January. And, we don't take Chris's data necessarily for, the ultimate answer to your point. Because he's a modeler. And so, for example, he had a vaccine coverage in Norway at 78% for measles. We have not had a case for the last 12 years of measles outbreak in Norway. So it must be higher than that. And our own records were 91. So that's the first departure of discussion to get ownership to the data on the 23rd of January. But then there is great, of course, interest in then seeing to transform that into policy. We have a very progressive health minister that has been upgraded from being a foreign minister, and so I'm optimistic that we will see actually some very significant outcomes from this discussion.
That's very good. Our managing editor, Hannah's in the audience. That's a department of error. Hannah, okay, get correction about measles vaccination in Norway. Jane?
In a way, my answer mirrors Tore's. We will launch this piece of work, although we're still discussing whether we've nailed the date or not, but we will do this. We will have a launch of this in Australia. We used the last global burden of disease. We did our own piece of analysis using our own data. It's been extensively used throughout our system. And in a way, the description of the UK revelation about things that people were surprised about, I'm actually looking forward to, and we've actually already commissioned another piece of work to look at where our data sits now. We've actually just completed a new national health survey, which is going to be a rolling survey, which includes all the things like bloods, etc. We'll use that data together with all of this new methodology. And don't know whether I'm excited, but I'm certainly eagerly anticipating seeing what it is that we don't know. We think we know very well where the burdens are in our society, but I bet you any money when we have another look at it from this frame, we'll find things we didn't know, and then we'll tackle them.
Very good. Christian, you're the only one who's mentioned economics in the panel so far. So issues about trade, and how do we get that into this discussion?
I don't want to go at that one.
Well, I privatize myself, so I prefer not to. From the global burden of disease.
I know. It's a tangential.
That's a tangential. Well, let me take it in a different way. I think for me, so I have a son who drives me nuts when we go on vacation. And we go from Washington to Vermont. It lasts like 7 or 8 hours. And he asks me all the time, not anymore much, but are we there yet? Okay? So are we there yet? and I will connect to your question. And I think I learned that for a few years in multilaterals. So we are there. I think epidemiologists just described the world for us enormously, and they basically put in front of us the size of the problem. Now, nobody decides to allocate resources and fund efforts based on the size of the problem only. People allocate resources on the size of the problem, on the feasibility to solve it, and on the returns on the investment. And that is related to the cost. So I think there is a next step, which is the translation of the global burden of disease on the so what for policymakers. And part of that discussion is so what on economic development. We talk very lively and very loosely that investing in health is huge return on economic growth. I think we have not done the homework yet to persuade ministers of finance to actually internalize that discussion and actually invest on that. So I see the global burden of disease as a fantastic first step towards actually persuading the guys I used to work with in actually putting the money in maximizing or increasing health.
Great answer, great. Now, hang on a sec, Jane. I just want to come to Mickey, because, Mickey, I always think of you as the philosopher. So now the question about philosophy, which I didn't quite fully but how do we rethink then our philosophy about disease after this study? I'm sure that wasn't the question, but I'm reinterpreting it just for the sake of giving Mickey a helping hand here. At UNICEF, for example, what are you going to do with this?
Well, someone mentioned Karl Marx, and he was a philosopher, and he's one of his proudest achievements to begin with. He sort of claimed to have turned Hegel from his head to his feet. Now we're getting into
deep philosophy. Okay, fantastic.
And so I think one of the consequences of this work and the subsequent collaboration and opening up of data sources and sharing of best practices would lead to, as has been said, a much more scientific and rational approach to priority setting and giving voice to the voiceless, as has been said. But I do think that will ask serious questions around some of the values that we're putting on some of these things, and particularly the challenges, as has been mentioned during the day, of how much information is too much information, and how much is it that we still need to recognize that some of these values are context specific, and that people and civil society in those who are suffering those things or in those places, how much more of their voices and values maybe need to come out much more and much more transparently than they've done so far in this sort of magic box of, we have these prevalence numbers, we have this magic box of giving weights, and then we have this back pain becomes
just a specific question, because yesterday WHO did issue a press release which largely mirrored the comment that was in the journal issue, but they said that they're hosting a meeting in February to take stock of the approaches to global health estimation, and I know they've invited IHME to that, and global burden of disease. Is UNICEF invited to that as well? So you'll be around the table. So in February there's going to be a huge powwow to go through all of this stuff and what it means for... Oh, really? Really?
No, well, we have to... I think it's going to be important.
Chris, did you see that? It was... Mickey did that.
No, Chris and I have had good conversations, and we've actually had... we actually invest in some of the work following already in terms of countries, and Emanuela were talking over tea time around, looking at the global burden of disease, but then also looking at the investments that countries are already making, and looking at this mismatch that we're having. So it's not just this part of IHME which is going to be important moving forward, but the other parts of the institution, which is really looking at health systems and their functioning, is going to be important as well. So I'm really looking forward to getting these things on the table and moving forward, because this is the big opportunity.
Very good. Jane, I know you wanted to comment.
I just wanted to make a comment in relation to the question about TRIPS, and not so much in respect to TRIPS, and we all know that's desperately difficult and hotly contested, but to make a broader point about some of the trade issues. Most people know about what we're doing on plain packaging on tobacco. You probably know that I've had a High Court challenge which I've won, but I have the biggest ever WTO dispute, which is currently on foot. More countries signed to the WTO dispute than has ever signed to a dispute before. But also we have a bilateral investor trade dispute. One of the companies took all of their business, took it to Hong Kong, and now they've notified a dispute under the bilateral trade agreement we have with Hong Kong. So take from this clear message in what we've seen about the impact of tobacco. It's very, 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 very clear, and there are a number of other impacts in respect of other things we're going to have to tackle over a period. I think we all need to be aware that and we're behaving as very, very good model corporate citizens in relation to the WTO issue. We've said we'll treat it absolutely fairly and legitimately, and I have officials running to and from Geneva on a virtually daily basis. But people do need to understand that there are other mechanisms out there which companies who don't like what we would consider to be perfectly legitimate public health actions in response to the kind of data we've seen today, which people will try and take against us to stop us doing what we should to protect public health. And I just wanted to make that point.
Very good. And I must say, Jane, while we're here, we do, I think many of us in public health really admire the leadership that Australia and you have shown in terms of dealing with tobacco. I think it's an example to all of us for that.
Thank
so
you.
very important to acknowledge it. Right, back to you. Yes, please, sir.
Thank you. My name is Daraj Jakabada. I am from the African region of WHO. It's not only Colin that
Very good.
is represented here. It's a great work, and we thank and congratulate Chris and Lancet for making this, for sharing this widely. As you mentioned, we are looking forward to the February workshop or consultation to learn more and to discuss with IHME, and then probably WHO would also jump on the wagon. I know also IHME were doing a consultation with PAHO, that's the American region, and actually we had a discussion with Professor Raphael at some point of a similar kind of consultation in the African region that may happen after February. I just wanted to say this.
Thank you very much indeed. I appreciate that. Other points, people? Yes, please.
Yeah, my question is...
Just tell us who you are for a second.
Sorry. I'm Peter Walia. I'm representing PF. Yeah. Now, my question is, in most cases, when people are talking about health practices and how to prevent disease and stuff like that, they do not follow obvious things, like, say, when it comes to smoking, I get very surprised. Like, for instance, in our country, we were supposed to be the first country to ban smoking in buildings, because if you look at the population, it's the reverse of this side. Most people in Zambia do not smoke. When they start smoking, it means they have grown old. Now, why should the big powers encourage the growth of tobacco, which feeds the appetite of smoking and therefore results in disease and other stuff? In the first place, smoking is not even nutritious. And then you you look at the people who are supposed to set examples, like, say, the medical doctors, they are the real smokers. And you wonder. And then on the economic part of it, because the doctor mentioned about it, the thing is, these habits of smoking, growing tobacco, and what have you are sponsored by the big countries.
Can I
because
just ask if there's a specific question you want to make?
what I want to ask is, how are you going to implement the policies so that the growing of tobacco and other habits stop? Because it's up to governments to own the policies.
Okay, very good. One more. Yes, please. Just going to say that. One more question, then come back to the panel.
Sudha Jayaraman, I'm a trauma surgeon at Brigham and Women's Hospital. It's a pleasure to be here. So my question is, so now we have a sense of the burden of disease. Can we map our health expenditure to this burden? And can we also map our research expenditure to this burden? Because to me, the research expenditure should come out of what we've identified as the problems, and I'm sure it is not.
Thank you. That's an extremely good point. Now, I want you to take in the comments you've had from the audience, but in your final no more than 45 seconds each, the question I would also like you to ask is, what is the one thing that you would advise us to do next based upon what you've heard today? The one action that you think should take place next. And I'm going to start at the other end this time. I'm going to start with Chris. One action and any answers you would like to give.
Go. On the expenditure question, I think that's an incredibly important issue. It's one that we hope we will start to address, which is lining up where the money goes by disease and injury, and also the dimension of the research fundings. I have a hypothesis that if we do that, we'll find that there's an incredible underinvestment in research around the disabling conditions, because we're still quite obsessed by premature mortality on the research side. Comment on the one action from today, is it, are actions around the burden of disease allowed in this response?
Yeah, absolutely. Anything you want. One. You can be flying off to the Bermuda for a holiday if you want to.
I think the one action that we have to figure out is, how do we deal with the 187 problem? Yeah. Which is that there is a value in reaching out, having the policy dialogue in 187 countries based on the results, but we don't really have the capacity across even though there's 487 of us, it's still not quite obvious how we're going to do that in all the places where it's important to do.
Absolutely, absolutely. Christian.
So please ensure that this is no longer an episodic effort of global burden of disease, but it's a continuous process. That the capital you build with 486 plus the pro bono contributions that were mentioned before are actually continued. And in that effort, just launch the policy translation. We need to have a policy translation. Excellent. The first step of the 187 solution is beginning to come up with how you translate this and what countries need to do.
Thank you. Jane, one action.
One action would be to work on how one communicates this, because if you can't explain it in simple, accessible language, it doesn't matter how many words you use, they will fall on very stony ground.
Thank you very much. Tori.
So I agree with Chris. A road show in terms of visiting countries at their own request, in terms of the relative benchmarking, I think is the top priority. I would like to challenge my Swedish colleague to invite Chris for the 24th, and then he can use Norway as a benchmark for Sweden.
That's great. There's something between Norway and Sweden, isn't there? Mickey?
Obviously, turn up for February's meeting because that would be, in terms of engaging with countries, having the UN organisations behind you to do that would be a big step forward to doing that. And so for us, it would be about engagement and opening up and so forth.
Very good. And First Lady?
I guess one action is in line with what has been said, is really help countries on the database and be able to move with priority setting and formulate policies. And if I may add, I think it was really evident that from at the beginning of the presentation, in terms of collaboration, Africa didn't collaborate so much. There were only few sites, and it would be nice to build capacity in Africa so that we can have more input from the African side.
That's wonderful. That's a wonderful vision.